Today is actually it's a special meeting. It is not a routine NAC meeting, since we have a guest from US, Dr. Mahesh Krishnan, who is here to talk to us about. I think his talk is titled "Taking Your Existing Dialysis Unit to the Next Level." So to proceed with today's meeting, we have two chairpersons. Dr. Hiramat is on his way. He just called me and said he'll be at any moment. And Dr. Dilip Rangarajan, please come. May I request Dr. Mahesh to be the chair.
So we've come a long way, but whether all these innovations are translated into better outcomes in dialysis is not very clear, because there is a review article in 2008 in CJSN where they've said that with 20 years of innovations in dialysis, unfortunately it has not really translated into better outcomes for dialysis patients. Very eager to listen to the speaker today to know whether there's any further change in that.
So, as the chairperson said, we've made a lot of innovations in the last 20 years of dialysis, in the technology, in the delivery of the fundamentals of dialysis. And we may have not made too much of a change. The mortality rate in the United States for dialysis was still 20%. And so we know that that's a problem. A recent paper that was published by Dr. Ray Hakim showed that the mortality rate for the first 90 days was much even higher than that. And so at DaVita, one of my roles has been to think about how to best address that issue. If it's not technical and it's not about the machines, what else could it be? Are there other things that we should be doing to improve the lives of patients with kidney disease? The way that we think about this is represented by the clinical pyramid, and this paper was published in CJSN a year ago, 2 years ago now, by Dr. Alan Nissenson, who's the Chief Medical Officer in the US. And what he describes is that overall, and he's devoted his life to dialysis, that for many years we focused on the fundamentals. And I'll show you what those fundamentals are. And those fundamentals are very important as the base of the pyramid. If one does not have good control for the fundamentals, then everything above it falls down, just like a house. If you don't have the first story built well, then everything will fall apart. But the question is, are there more complex programs that we could manage, that we could improve the patients' lives, we could improve their quality of life? And then the next question we talked about at DaVita was, what could measures of effectiveness be? If we were to look at outcomes management, we've been able to do great things for adequacy. We've been able to do great things for anemia control. We've been able to do great things for phosphorus control. But is that really the right measure to look at, or are there other measures we could look at? And so we put ourselves in our patient's shoes. We said if we were the patient in the chair or in the bed, and we thought about what matters most to us, how would that be? And so we thought about what those measures of effectiveness are and what matters most to the patients. And so this has led us to my talk today, which is, while we have done really well in the fundamentals, whether that's due to anemia or adequacy, in the US we have a big problem with dialysis access. I actually took the slides out for the Indian audience because you do to show you some of the numbers from the US. But that's very fundamental to getting things done. And the question is, what else could we do? And we have isolated some additional things that we all worry about, but we maybe are not as systematic or rigorous about as we are for adequacy and some of the other things. And while there are many things that we're working on, I will concentrate today on 3 topics. The first is an issue that's probably very near to your heart and my heart and the patient's heart, which is fluid management. So the fluid management is a very complicated problem. And so I'm going to talk a little bit about what we've done there to try to improve outcomes. And the second thing that we realized, especially with those papers by Dr. Hakim and others, is that pre-dialysis education is very important. We've done some work, I've published some work that shows that if patients receive adequate pre-dialysis education, pre-SRD education, or even CKD education in general, their outcomes are much better, both in stage 3, stage 4 kidney disease, as well as when they start dialysis, they're better prepared, they have better outcomes. So we'll talk about that. And then I will talk about the IMPACT program, which is the first 90 days of dialysis. So there, The program that we have adopted is the modified version of a program called Right Start, which Dr. Hakim published in CJASN in 2007. And in that, we identify that those patients new to dialysis are almost like the patients that are in the ICU. You have to do a little more care for those patients in order to reduce their morbidity and mortality. The measures of effectiveness of how well we do are not just laboratory values. The measures of effectiveness of what we do are, if you're a patient, you'd be very concerned about mortality. Is it the case that I survive longer or I survive shorter? Hospitalization and rehospitalization is a big topic. We know that hospitals sometimes aren't good places for dialysis patients, and patients too often leave the hospital and bounce right back again. So that's something that we looked at. And then the patient experience of care. How does the patient feel about the dialysis unit? How do they feel about their quality of care? Sort of the medical consumerism, that's the other question. And then what matters most is the health-related quality of life. I think this is most important for us that have been ill or those that have seen loved ones become ill. We're willing to pay, we're willing to consult people, we're willing to trust in order to regain that quality of life that we've lost. And so that's a very important thing to think through as well. So when we looked at how to design these programs, and we asked ourselves, why is it that despite massive improvements in adequacy, massive improvements in some of the other fundamentals, we have not seen any improvements in morbidity or mortality? We looked at what causes hospitalizations. And this is data that's obtained from the USRDS. These are DaVita patients in the US. In the United States, DaVita dialyzes 175,000 patients in 2,200 facilities with about 4,000 nephrologists. And what we see here from the data probably won't surprise you, and I'll show you some data from India as well. But this basically shows that fluid-related excess, fluid-related overload accounted for about 30% of all admissions in the United States and all of the different subcategories that they're there. The second program was around infection, and we noticed that there vascular access infection, septicemia, and even vaccine-preventable pneumonias accounted for around 20% of admissions. And the diabetes, and in the US as in India, diabetes is a leading cause of renal disease, accounting for 5.1%. And so when we looked at this, we thought, well, if we're going to try to improve outcomes, morbidity or mortality, we looked at this in 2009, we should try to focus on these conditions that are causing our patients to go in the hospital. And this is a paper, I think, from that many of you may know here in the audience around a similar story from India in terms of this, from the Indian Journal of Nephrology in July of 2014. And here again, the common themes are fluid overload, cardiovascular disease, and infection. And so all of these, I think, are a good sign to say, what are the next level programs that we should think about? So I'm going to spend some time on fluid-wise. There are a number of other programs that we have developed to try to improve mortality and morbidity. Fluid-wise is the one I'll concentrate on, which is fluid overload. There are other programs that we have to reduce infections and infection control, to improve the medication management and adherence for patients. And step ahead is our program for diabetic foot and amputation, because it's a big problem for patients with diabetes. The vascular disease that leads to progressive renal insufficiency also causes secondary complications as well. Ophthalmological disease, peripheral vascular disease, peripheral arterial disease, all of which causes patients to lose limbs, and that's that program. So when you think about fluid-related hospitalizations, and this again is USRDS data, which is a large renal registry, predominantly of patients over the age of 65 in the US Medicare, you see that directly fluid-related admissions, fluid overload and heart failure, represent around 20 admissions per 100 patient years, and that directly or indirectly related efforts due to fluid excess account for 55 admissions per 100 patient years. And this varies. In the United States, we have Medicare, and in order to get paid, the hospital has to bill Medicare. And the more sick the patient is, the more the hospital gets paid. And so sometimes the hospitals upcode. They try to give the most diagnoses to get the most money. So we always take the claims data with a little grain of salt. And when you read the data that comes from the USRDS and others, you should know that the hospitals have an incentive to have people be slightly sicker on paper in order to get slightly more money back. And so it's something just to think about. One of the things that we looked at was a metric. We thought to ourselves, fluid management is a very complicated problem. We do not have an objective way to determine how much fluid to take off the patients. When I learned how to do dialysis, they said, listen to the lungs, press the shins, see how much fluid there is. It's hard to really estimate then how much fluid there actually is. And so we were looking to say, is there a marker? Is there something like KT over V that we could apply that would tell us that patients have a higher risk of problems and we should think about them a little differently? The marker that we looked at and derived, and this was work done by Dr. Stephen Brunelli, who's published a number of papers in this area and is one of the other chief medical officers at DaVita, is the interdialytic weight gain greater than 5%. And what we looked at is how sensitive is this as a marker. We're all very sensitive to KTRV from the HEMO study and from a number of studies in the past. So we sought to see whether we could answer that question. And what we found is that if you look at the proportion of treatments in a given month that are consistent with an interdialytic weight gain of over 5%, that you see this risk stratification, that you see that as you have more and more of these treatments, the odds ratio of death continues to increase. And you can see here that the confidence intervals overlap for 11 to 20%, but don't overlap for greater than 20%. And so we thought to ourselves, that's a pretty good marker. It's very similar to the accuracy for KTRV and HEMO. And then the second one that we looked at was mistreatments. And in the US, this is very different than in India. In India, you have patients who, by economic necessity or other reasons, dialyze for 2 times a week. In the US, 95% of patients, probably more than that, actually dialyze 3 times a week. And so we could quantitate the odds ratio of death looking at mistreatments. And here again, you see that the more mistreatments that you have, the higher the death ratio is as well. And so we thought to ourselves, is this a good marker? Is this better than KT over V? Is this like a KT over V for fluid, an objective metric in order to try to reduce the patients having fluid overload? We also looked at some other metrics as well. We looked at the proportion of treatments where the post-dialysis weight was greater than the target weight plus 1 kilo. And again, we were looking for the right marker. And here again, you can see that the adjusted hazard ratios for death, adjusted for all the different things that you see on the bottom of the slide, continue to increase, suggesting that it is a good metric. And again, if we looked for these patients with mistreatments, again, a very good metric in terms of trying to understand if patients were going to have high morbidity and mortality. So then we asked ourselves, the best marker of those 2 that I gave you, the one that had the highest correlation, was this interdialytic weight gain of greater than 5%. And we thought to ourselves, within DaVita, who dialyzes that many patients, so we have millions and millions of treatments, what's the proportion of patients who have this interdialytic weight gain greater than 5%? And you see the distribution here. So there are a fair number of patients who actually, in thousands and thousands of treatments, where the interdialytic weight gain is greater than 5%. And so we thought that was a good marker. We then looked at the second definition, which was the proportion of treatments with post-dialytic weight gain plus greater than target weight plus 1 kilo. And again, we saw a shockingly huge number of events. And so we thought to ourselves, the first one seems like a very good marker. The second one seems to be a process failure. You would think that the target weight and the post weight should be pretty closely correlated. If the target weight and the post weight aren't closely correlated, then we decided that must mean that the dry weights weren't being reassessed frequently. And indeed, that was the case. When we went in, we saw patients who would go into the hospital, be dialyzed off, and this probably happens here as well, many, many kilos of fluid, and come back, and the dry weights weren't necessarily readjusted. And so that was a good marker for us in terms of process improvement. So then we said, what are the comprehensive metrics to try to improve fluid-related overload? And again, we first looked at the definitions, and based on the sensitivity and specificity of the graphs I showed you, we said, we need a marker for excess weight gain. We need a marker to understand if patients are gaining too much fluid in a period of time. And again, we use the interdialytic weight gain of greater than 5%. And we said, if this happens for greater than 10% of the treatments in the last 91 days, those patients are at high risk for fluid overload and need to be reassessed. Either either dry weights challenged, or the nephrologist needs to make another assessment, or the patient needs counseling. We need to figure out what to do with that. The second thing that we looked at was this curious phenomenon of the post weight above the target weight. That shouldn't be, right? If the dialysis technicians are doing what they're supposed to do, and the nephrologist is doing what they're supposed to do, you should not have post weight greater than target weight. And so we defined a definition of post-weight above target weight by 1 kilo or more for more than 20% of their treatment for the last 91 days, and we decided we would track that. The third one that we looked at was a metric that's also a signal that tells us that the dry weight assessment has not been redone. So this is post-weight below target weight, and you can read the definition there. And so this definition tells us that the dry weight needs to be changed as well. It's in the other direction. So the technician or somebody is dialyzing the patient to some number, and that's not what the prescription is. And so that in and of itself is a problem. And so that tells us that we need to go back and look at this. And in DaVita, we have a lot of data, so we can do all of these analyses, but it allows us to do all of these different analyses to understand which metrics to use and how to use them best. The last metric that we looked at was dialysate sodium. And over our 2,200 clinics, we had never standardized a dialysate sodium. We said, you know, doctor, whatever you think is reasonable for your clinic, that's what you should do. And in the US, we didn't measure serum sodium for dialysis patients because the insurance didn't pay for it. Somebody told me one time, the way healthcare is financed dictates the way it's organized and ultimately the way it's delivered. And the way that translated in this very important aspect, no one would doubt that sodium is a very important part of a nephrologist's life. We had no idea what the population sodium was looking like because we were never paid for it. But we decided that we would undertake a large study. We did, I think, 6,000 patients, and we sampled there. We added sodium to their monthly labs. And we found that a significant number of patients had a serum sodium which was less than the dialysate sodium that they were being prescribed. Well, we're very familiar with urea reduction ratios, where we're trying to establish a chemical gradient, taking the high concentration from the blood and moving it into the dialysate. And we're all very familiar that if the endotoxin levels in the water are high, you have a gradient which is higher in the dialysate, lower the blood, and endotoxin moves in. We don't think that's good. Well, if you picture the same thing happening with sodium, that's what we found, which was that the ambient sodium concentration of the dialysate was higher than the serum sodium, which meant that we were infusing sodium into patients. And so we said to ourselves, where should this number be? We used a lot of data. We determined that the right answer should be 138. And so we thought to ourselves, this would be a good marker. We went to our nephrologist partners and we said, these are the metrics we think we need to fix. These are the programs to fix them. And we implemented a number of different programs. What were those programs? The programs were to target weight management, because again, if the dry weight and the post weight were either too high or too low, that's a problem. That doesn't really suggest good management. And so we created continuous target weight assessment. And so we said on a regular basis, we need you to review the target weight and make changes. We targeted patients new to dialysis. We found that when patients first start dialysis, there's so much fluid on board when they transition from stage 4 to stage 5 that there's a guess made as to how much fluid should be removed. And that needs to be reassessed on a very frequent basis because you don't know where the patient's going to bottom out. We don't have an objective measure where we can say, okay, this is your dry weight. And so we needed those new patients to dialysis within the first 90 days to be continuously reassessed. And we implemented a system where every patient within one treatment or two of coming back to the dialysis unit, the target weight had to be respecified. Because again, if you went in, if you started at 40 kilos and you went into the hospital and they dialyzed you down to 35 kilos, and then your post weight when you came out of the dialysis unit was still, your target weight was still set at 40 kilos, that doesn't make any sense, but we found that was happening. So we implemented that for the target weight management. The second thing that we thought about was the intra-dialytic period, so the period that's happening during dialysis. And there we found that it was really necessary to do very accurate pre-weights and post-weights. And believe it or not, the way that people were measuring weights in some of the clinics was not very good. In the US in the wintertime, people come in with heavy jackets and coats. And if you put that patient on the scale with their heavy jacket and coats, it doesn't look right in terms of the weight that you're seeing. So we had to retrain everyone to say, okay, you can't have a coat, you can't be carrying the cane, you have to have the right weights. We wanted to ensure adequate fluid removal, and so we have set up a number of different programs to do that. Some of you may be familiar with some of the work by Chris McIntyre that's recently been published around, and Steve Brunelli as well, around the maximum ultrafiltration rate. And we found that we had prescriptions where the ultrafiltration rate was so high that the patients were becoming hypotensive during the dialysis session. And so we worked on how to do that. And lastly, we looked at the proper sodium balance. And this took two specific issues. The first, as I mentioned, was the standardization of the dialysate sodium to 138 across all clinics. And the second one was the issue of sodium profiling, which was mentioned earlier today as a technology. We also had the use of hypertonic saline in the United States. Is it used here in India for hypotensive episodes? No. Good. So when we looked at this, we conducted a rigorous evidence-based review of everything in the literature. We talked with the chief medical officers of the other organizations, and we tried to understand what the literature showed in terms of substantiating the use of both those two things, dialysis sodium modeling, as well as the use of hypertonic saline. And it became an urban legend. It's something that everyone believes should work, but the data does not substantiate that. And we did sodium balance studies in the dialysis unit, and we found that with these two practices, we were infusing a lot of sodium into the patient. In fact, I'll tell you a funny story. We were trying to come up with an idea to tell the nephrologist how much saline, how much sodium was being delivered with a bolus of hypertonic saline. And one of my dietitians came to me and she gave me a Bloody Mary mix. You get those on the plane. The Bloody Mary mix has almost 4 grams of sodium in it, right? Which is almost the equivalent of a hypertonic saline push. And so we used that example. And then, funnily, as I was flying back home from that meeting, I was on a plane and they asked if a doctor was on the plane. And a patient was hypotensive on the plane. And they don't have anything on planes, right? They have a stethoscope and a blood pressure cuff. And so I thought to myself, how can I get this patient some saline to bring their blood pressure up on the plane? But what do they have on the plane? They have Bloody Mary mix on the plane. So I administered the Bloody Mary mix at 40,000 feet, and the patient's blood pressure recovered nicely, and we didn't have to do anything different. So it was a good example of that. The third thing that we did was to try to understand the inter-dialytic period. And so this is a place where we don't really spend a lot of effort. We spend a lot of effort for the 4 hours or 3.5 or 4.5 hours that the patient is in the chair in the bed. But the patient has a life outside of the dialysis unit. The patient has a diet outside of the dialysis unit. And so we tried to think about how to better improve the patient's outcomes by dietary counseling for fluid and sodium, as well as dietary intake assessment. And on that was no Bloody Mary mix. They couldn't have Bloody Mary mixes. That was not allowed. So in order to do this systematic process, again, across a large health system, 175,000 patients, we had to do a lot of training. We had to retrain the technicians. We had to retrain train the nurses. We had to talk to the nephrologists to make sure they understood what we're trying to do. We implemented standard sodium, and it's a very daunting task. We have 40,000 machines in the United States, and so to have the biomed technicians standardize the sodium across 40,000 machines was not a trivial task to do. One person in every clinic to be the fluid advisor. That person's job was to make sure all the fluid programs got implemented. And we implemented a management process with all of those metrics that you saw. We used the electronic medical record to present these data on a monthly basis to all the physicians and all the technicians. In the US, we conduct what we call QIFM rounds. They do them here as well, multidisciplinary rounds, where we have the physician, who's the medical director, and the leader, the medical leader of the unit, along with the facility administrator, the head nurse, the dietitian, the social worker. And we made sure that every time they had one of those meetings, they could look at those metrics and see how the clinics were doing. So this is an example of some of the teammate and patient education that we have. You see here just some information on your left around what we put in all the clinics. You see here what the dietitians put up in terms of the salt, and salt matters, what foods had high salt and what foods have low salt. And you see some of the specific issues that we did to the patients, where we tried to educate them as well. We even gave the patients salt substitutes to use, because some of the patients were told not to take salt. In the United States, and I don't know if it's true here, the substitute for salt, if you say no salt, is potassium iodide, which is a problem in dialysis patients. That's not what you want to be giving them. And so we actually gave them, it's called Mrs. Dash. It's a combination of spices that are salty but not salt. So what happened when we did this? What happens if you go and you look and you build up this from the physiology to the mechanics of dialysis to the data, to the programs. This metric, remember I told you, is the percent of treatments with interdialytic weight gain above 5%. And here you see that within a short period of time, from 16%, this number dropped down to 12.2%. And this may not seem like a big number, but in relative terms, it's a 20% reduction in this metric. And this is being affected across 175,000 patients at once. The second metric is the percent of patients with greater than 10% of treatments in the last 3 months with an interdialytic weight gain of greater than 5% of target weight. And again, here you see from 47.4% absolute, a reduction to 38.3%. Again, a very substantial decrease. And overall, we saw that this actually improved significantly over time. So let me give you an example of what this looked like. This program was instituted in January of 2013, and this was the histogram distribution of interdialytic weight gain as a percent of target weight. Within a short period of time, within 6 months, we saw a gradual shift to the curve. And it may not look gradual to you, but when we see shifts at that scale, it means it's fairly significant because of the scale of the movement. And what we saw by January of 2014 was the curve had shifted dramatically to the left. And so that continued to give us confidence in what we wanted to do. We then looked at the hospitalization data, and the data is still being crunched, but we saw a reduction in mistreatments. So again, I told you mistreatments was an important aspect. We saw a substantial reduction in mistreatments, and we contributed that to less fluid-related overload. In the United States, the claims data from USRDS lags by 2 years. So even though the annual data report came out for USRDS in September of last year, 2014, it only reflects data through calendar year 2012. So we don't have the hospitalization data yet, but I'm confident that because the mistreatments have gone down, that many of those are due to less hospitalizations. And so I give this to you as an example of how you can take the basic physiology and translate that all the way up to improving a population-based approach. Now I realize that some of these programs are vast and require a lot of resources. In the talk today in Mumbai, they said that the US has the insurance Raj, who's able to pay for all of these different things, and clearly that's a different aspect here as well. But Suresh has taught me this term of jagad, which is, I think, an interesting approach to where you take these very complicated programs and figure out a way to make it work within the confines of your own healthcare system. And so I give this to you as one example of that. The second program I'd like to talk to you about today, which is a complex program, is the IMPACT program. And this program was targeted to reduce mortality in the first 90 days. Remember I told you that patients who are new to dialysis have a significantly higher morbidity and mortality within the first 90 days. And so the background here was, for patients beginning dialysis, we identify those patients as needing ICU, intensive care for those patients. And so we developed this program called IMPACT to improve outcomes through standardized care. So we identified this instant patient management for patients action-centered on treatment. And we essentially created a completely different management process. When the patient transfers in your hospital or your clinics from the floor to the ICU, the care changes. The intensity changes, the number of people that are involved change, what they're monitoring changes dramatically. We implemented that same mentality for patients new to dialysis, and we actually changed an entire mindset around doing this. The first 90 days was chosen very deliberately. So we again did data to try to understand where the inflection point was. We leveraged the data that was done by Dr. Hakim in 2007 and C. Jason, and we looked at the percent of first-year incident patient mortality by quarter before IMPACT. And here you see that 44% mortality. Remember, I told you in the US, the mortality at this time was 20%. So the mortality in the first 90 days, double that. That's a significant amount. You pick a mortality for a cancer. You find some cancer and you say, what's the mortality for a cancer? It's not 44% in 90 days. That's an incredible mortality. And you see here where the other mortality data shakes out. So we thought to ourselves, again, we took a very evidence-based approach, very similar to the fluid management approach that we took earlier. And we asked ourselves, what are the most important things? And being nephrologists, we had to come up with a good mnemonic to remember these things. And so we said it's the 4 A's. The 4 A's were access. And again, this is the US where the instant catheter rate can be as high as 50% when patients first start dialysis. And so we said we need to have an access place very quickly. The second thing we said is the adequacy very quickly has to get to 1.2. If it doesn't get to 1.2, we're not doing our jobs. The third was anemia, and so we wanted to ensure that the patients could get to their target hemoglobins, which at the time of this program was a hemoglobin of 10 to 12. And we wanted to improve the nutrition, and I can't stress this one enough. I think you have a similar issue in the United States, in India, where as patients progress through stage 3 and stage 4, we tell them to protein restrict their diets. We tell them not to eat a lot of protein because we're afraid of the buildup of uremia, and that may progress to dialysis much sooner. But then when you shift from a pre-dialysis setting one day to a dialysis setting the next day, you go from a regular state to a hypercatabolic state, potentially with significant amounts of inflammation. And we were finding that many of the patients weren't necessarily making that shift. They were continuing to pursue a low-protein diet because no one told them to do any other. And so that was a huge problem, and this was causing a significant amount of morbidity and mortality. So in this program, we looked at those 4 metrics. We used the electronic medical record, and we actually, in those monthly rounds, asked to focus on those 4 A's: the access, the anemia, the adequacy, and the albumin. And here you see the percentage of patients who met or exceeded that goal. And you can see that this program started after the publication, and it went from a low number of 77.8% all the way up to 90% over time. So what happened when you did this? Again, we are interested in changing the outcomes. And this is a peer-reviewed paper that was published in AJKD by myself and others in 2010. And essentially here, we saw that the intermediate outcomes improved. A higher proportion of patients within the program actually dialyzed with preferred access at 90 days. We found that the intense management of instant dialysis patients was associated with a statistically significant decreased mortality in the first year of dialysis. And we found that the focused attention to care in instant patients is an important part of the dialysis program. To emphasize that point, I'll show you some of the outcomes here. The first column is those patients in the group that we studied. We conducted this in 1,000 patients. The second group is in 2,000 patients. And to do this study, we conducted a propensity score match. So we identified the patient characteristics that were related to the patients in the program, and we created a virtual control group out of the database for other patients. This is also called, I think now it's called a Pragmatic clinical trial, where we essentially did this in the electronic medical record for a fraction of the cost it would take to do an RCT, and we still get some meaningful results. And what you see here is that overall the hazard ratios improved, and overall we saw a statistically significant improvement in overall mortality, which suggests that if you were focusing on some of these other aspects in conjunction in the ICU mentality, you can actually achieve superior outcomes. The last and final program I'd like to talk about is pre-dialysis care. And so pre-dialysis care, I think, is very important. I published a paper a few years ago in the DOPS database, and there's others, which show that the length of time that a patient sees a nephrologist prior to the initiation of dialysis is linearly correlated with improved survival on dialysis. Again, the patients are better prepared, they're more likely to choose the right access, the right modality. And so when DaVita thought about how to fix this problem, this was a big problem for us. In the US, we're a dialysis provider. We're not like Nephrolife is here, where we employ the physicians. And so the question was, can we provide some sort of education to improve the care for patients pre-dialysis? We were just in CKD. And we thought about this long and hard. DaVita's mission is to improve patient care in general. And so we decided we would launch a non-branded open source application for the community to see this. And to date, since August of 2012, when the program was started, we've educated nearly 10,000 CKD patients in the United States. And we have an Indian version of the website now up at kidneysmart.in. It's a non-branded, and you can actually look at it, and it actually allows you to use it within your practice. So what are the benefits of CKD education? What do we do in this program? So Kidney Smart basically shows you, and I think Baxter had a significant program here in India, if I remember correctly, which was extrapolated from things they did in Europe and in Asia, in the US. We found that patients who are exposed to CK education are better choices, they will make better choices. They're 4 times more likely to start with a home modality. Now, I understood from the conversation just before the presentation that economics also dictate which patients get on which modalities. But in the United States, the modality is actually, it's actually cheaper to be on peritoneal dialysis We have a significant number of home hemodialysis patients as well, which is a good modality, which is being started here in India. And so it's important to do that. The second is they're 2 times more likely to have an ideal access in place. Again, very important in the United States where the catheter rates are so high at initiation. So what do we do in the website? And this is done now globally. The screen that you see on the top is actually the Spanish version of this that was deployed in Colombia and in the US. But we also have the English version. And we try to educate the patient. We try to tell the patient how kidneys function, what are the common causes of kidney disease, the importance of medication, diet, and lifestyle. And we go through all the different treatment options. And when I say all the different treatment options, it includes not just hemodialysis or peritoneal dialysis or home hemodialysis. It also includes transplant, because transplant is a treatment option for patients. It also includes what is now being called conservative care, and there's a different definition of what that looks like, which is patients who decide not to do dialysis, and they do not palliative care, but supportive care in that regard. So that's a third thing that's offered. So this is an example of the syllabus that's seen for the Kidney Smart classes, and you can read it there. All the detail is in there. It's done in a very patient-friendly manner, and it's meant to supplement the patient education and reinforce the things that you may talk to the patient about in your clinics. But when you go home, you realize that not only must the patient be re-educated sometimes, the family has to be educated as well. And it's hard to have the family come into the OPD and do that with you, but sometimes it's possible to do now with the internet, and so this is one way of doing this. So I'm going to start to close the talk with, in the end, what matters most. We talked about whether or not patient outcomes actually improve. And you've seen that I've shown you a number of programs that we've done to try to improve morbidity and mortality. We talked about fluid and the importance of fluid assessment and fluid removal. We talked about pre-dialysis education with Kidney Smart, and we talked about the first 90 days of mortality. This is a data set now from the United States, from a new organization. The contractor that previously had the USRDS, the University of Minnesota, no longer has the USRDS. But they still are very interested in doing this research, and so many of us, including DaVita, are sponsoring them to do some new work. And so if you ever need new slides in the nice graphic format that have been done in the past for your talks, if you go to purekidney.org, you can download all those slides. But what I want to show you here on the top is first-year mortality for instant dialysis patients over time, and mortality for prevalent dialysis patients over time. And what I want to point out is the curve is actually bent. Right? You're seeing improvements in overall mortality and morbidity for both patients new to dialysis as well as incident patients. The common knowledge is, the common conception is that 1 in 5 patients die, that the mortality rate in the United States is 20%. I can tell you that DaVita, when we exited 2014, our mortality rate was 13.54%. And so we do think these programs are actually working. But again, it's a slight change from where we were before. We had focused so on the fundamentals that we didn't go into some of these complex programs. So that's, I think, one thing that we attribute to this improvement. Now, clearly there are other things as well. Cardiovascular care for patients has improved dramatically. We're seeing more angioplasties, more cardiac interventions. In the past, in the United States and globally, there was what I would call a therapeutic nihilism for patients on dialysis. That they felt, oh, they're end stage, we see that word end, there's no reason to do angioplasty, there's no reason to do bypass. I think that's clearly not the case anymore. So I think there are many other factors that are contributing to this improvement in mortality and morbidity. But I have to think that some of the metrics that I showed you before are contributing to that as well in terms of reducing the mortality and morbidity. And after all, I think that's most important. You remember in the pyramid that was published in C. Jason by Dr. Dickinson, that quality of life for the patients is most important. And we tend to think a lot of patients are like the ones here on your left, which are the ones in the clinics and in the dialysis units, either in their chairs or in their beds. But many of us know that in the intra-dialytic period, they're not patients. They are grandmothers or grandfathers, they're husbands or wives, and they want to live full lives. And so I think it's very, very important, that commitment to quality of life, and that focuses on all the things I talked about before, reducing mortality, morbidity, and improving the overall patient quality of care. Thank you. Program. So Kidney Smart basically shows you, and I think Baxter had a significant program here in India, if I remember correctly, which was extrapolated from things they did in Europe and in Asia, in the US. We found that patients who are exposed to CK education are better choices, they're able to make better choices. They're 4 times more likely to start with a home modality. Now, I understood from the conversation just before the presentation that economics also dictate which patients get on which modalities. But in the United States, the modality is actually, it's actually cheaper to be on peritoneal dialysis. We have a significant number of home hemodialysis patients as well, which is a good modality, which is being started here in India. And so it's important to do that. The second is they're 2 times more likely to have an ideal access in place. Again, very important in the United States where the catheter rates are so high at initiation. So what do we do in the website? And this is done now globally. The screen that you see on the top is actually the Spanish version of this that was deployed in Colombia and in the US. But we also have the English version. And we try to educate the patient. We try to tell the patient how kidneys function, what are the common causes of kidney disease, the importance of medication, diet, and lifestyle. And we go through all the different treatment options. And when I say all the different treatment options, it includes not just hemodialysis or peritoneal dialysis or home hemodialysis. It also includes transplant, because transplant is a treatment option for patients. It also includes what is now being called conservative care, and there's a different definition of what that looks like, which is patients who decide not to do dialysis, and they do not palliative care, but supportive care in that regard. So that's the third thing that's offered. So this is an example of the syllabus that's seen for the Kidney Smart classes, and you can read it there. All the detail is in there. It's done in a very patient-friendly manner, and it's meant to supplement the patient education and reinforce the things that you may talk to the patient about in your clinics. But when you go home, you realize that not only must the patient be re-educated sometimes, the family has to be educated as well. And it's hard to have the family come into the OPD and do that with you, but sometimes it's possible to do now with the internet, and so this is one way of doing this. So I'm going to start to close the talk with, in the end, what matters most. We talked about whether or not patient outcomes actually improve. And you've seen that I've shown you a number of programs that we've done to try to improve morbidity and mortality. We talked about fluid and the importance of fluid assessment and fluid removal. We talked about pre-dialysis education with Kidney Smart, and we talked about the first 90 days of mortality. This is a data set now from the United States, from a new organization. The contractor that previously had the USRDS, the University of Minnesota, no longer has the USRDS. But they still are very interested in doing this research, and so many of us, including DaVita, are sponsoring them to do some new work. And so if you ever need new slides in the nice graphic format for your talks, if you go to purekidney.org, you can download all those slides. But what I want to show you here on the top is first-year mortality for incident dialysis patients over time, and first-year mortality for prevalent dialysis patients over time. And what I want to point out is the curve is actually bent. Right? You're seeing improvements in overall mortality and morbidity for both patients new to dialysis as well as incident patients. The common knowledge is, the common conception is that 1 in 5 patients die, that the mortality rate in the United States is 20%. I can tell you that DaVita, when we exited 2014, our mortality rate was 13.54%. And so we do think these programs are actually working. But again, it's a slight change from where we were before. We had focused so on the fundamentals that we didn't go into some of these complex programs. So that's, I think, one thing that we attribute to this improvement. Now, clearly there are other things as well. Cardiovascular care for patients has improved dramatically. We're seeing more angioplasties, more cardiac interventions. In the past, in the United States and globally, there was what I would call a therapeutic nihilism for patients on dialysis. That they thought, oh, they're end stage, we see that word end, there's no reason to do angioplasty, there's no reason to do bypass. I think that's clearly not the case anymore. So I think there are many other factors that are contributing to this improvement in mortality and morbidity. But I have to think that some of the metrics that I showed you before are contributing to that as well in terms of reducing the mortality and morbidity. And after all, I think that's most important. You remember in the pyramid that was published in C. Jason by Dr. Dickinson, that quality of life for the patients is most important. And we tend to think a lot of patients are like the ones here on your left, which are the ones in the clinics and in the dialysis units, either in their chairs or in their beds. But many of us know that in the inter-dialytic period, they're not patients. They're grandmothers or grandfathers, they're husbands or wives, and they want to live full lives. And so I think it's very, very important, that commitment to quality of life, and that focuses on all the things I talked about before, reducing mortality, morbidity, and improving the overall patient quality of care. Thank you.